Okay, hello everyone. Back to Biopticka Multihead slide seminar. Marian Schwadler speaking. Today I've got only three quite simple cases, but quite nice. The first case is as you can see, skin biopsy. It's umbilical tumor. Umbilical skin tumor mass and as you can see, the epidermis is quite innocuous, it's intact, and under the epidermis you can see these ugly looking adenocarcinoma structures. So we are dealing with adenocarcinoma involving the skin of the umbilicus. I have performed some immunohistochemical stains, and the lesion was positive for cytokeratin 7 with a little bit of cytokeratin 20 co-expression and weak and focal CDX2 expression, and tumor cells also showed SMAD4 protein loss of expression. So my diagnosis was adenocarcinoma involving the skin of the umbilicus. It's secondary, it's not primary skin adenocarcinoma or skin adnexal carcinoma. And the probable origin is somewhere in pancreatobiliary tract or maybe in the stomach. But with this morphology and CK7, little bit of CDX2 positivity and loss of SMAD4, I would go with pancreatobiliary carcinoma. So this lesion has got a very nice eponym used, and the lesion is sometimes called Sister Mary Joseph nodule, and it was named after obviously Sister Mary Joseph, and she was working in that time. It was called St. Mary Hospital in Rochester in Minnesota, and now it's called Mayo Clinic. And she used to serve as a surgery assistant to Sir William Mayo. This was the leading surgeon, leading physician of that institution, and the institution now bears his name. So this is Sister Mary Joseph nodule, and this is quite nice historical vignette, and Sister Mary Joseph was first to pay attention to these nodules, and William Mayo eventually published as a first physician this case report, and from that time it's called Sister Mary Joseph nodule. Most frequently, it's a metastatic from gastrointestinal tract or genitourinary tract, and prognostically, it's a sign of very bad prognosis. So it's obviously very advanced disease. Sometimes no primary can be found. So in this case, it's probably pancreatobiliary or stomach, but I don't have any clinical follow-up in this case. So I will include this very short review article about umbilical metastasis in our web pages. All right. My next case, it's again very easy biopsy because I knew the clinical history of the patient, and this is obviously bone lesion, and we've got this solid ugly looking epithelioid neoplasm, it's carcinoma. And it's an older male, and his clinical history was prostate cancer, and bone is obviously one of the most frequent sites where prostate cancer metastasizes. But it's, the morphology is definitely suggestive of prostatic origin because it shows these ugly looking cells with very conspicuous nuclei, but we have to perform some immunohistochemistry to confirm that it comes from the prostate and patient does not have some other malignancy as well. So the best marker so far was NKX3.1, and it's here, so it shows this very nice nuclear positivity. But recently we have introduced a new antibody in our lab for prostate origin, and it's called HOXB13. And it shows again this very nice, crisp nuclear immunoexpression. So this is a new antibody for prostate origin, but also it stains some other malignancies or tumors, including myxopapillary ependymoma. And it's really useful marker to distinguish myxopapillary ependymoma from conventional type of spinal ependymomas. In addition, some other tumor types are positive for HOXB13, including hindgut neuroendocrine tumors. Okay, so also in this indication, it may be useful to confirm the origin of well-differentiated neuroendocrine tumor metastatic somewhere. HOXB13 points to hindgut origin. So I will include these papers and maybe, this is very important paper, HOXB13 in localized and metastatic prostate cancer. And in this paper, they showed that even in differentiated tumors with neuroendocrine small cell differentiation show retained HOXB13 immunoexpression. So it's very good marker even if you are dealing with dedifferentiated prostate cancer. The staining is still retained. So and the marker is probably better compared to other conventional prostate markers. So this is our new prostate adenocarcinoma marker mainly. And when speaking about myxopapillary ependymomas, these authors propose that HOXB13 immunoexpression should be as one of criteria to diagnose myxopapillary ependymoma, and probably this would be included in the following WHO classification of CNS tumors. Okay, so this was my second case, and my last case is again very easy but very nice. This is, let's say, middle-aged female, and it's meningeal tumor, and as you can see here, it's probably meningioma. Okay, morphology is quite nice and suggestive, but in this case, it's one of many variants of meningioma, and if you look carefully, you will start seeing these very small lumina with this eosinophilic secretion within the lumina. It will be PAS staining positive. And maybe if I show you one another stain. It's immunohistochemistry for carcinoembryonic antigen C.
Secretory meningioma.
Yeah, it's secretory meningioma. You can see it's CAE immunopositive, and these patients may have elevated levels of carcinoembryonic antigen in their serum, in the blood, even at the levels suggestive of some internal malignancy. So this is a biochemistry pitfall. So it's just meningiomas with these cells capable of carcinoembryonic antigen secretion. So this was my last case.
It's described by Alvarez Saavedra in 1987.
Okay.
Okay, let's continue. I will start with, here's Michael Senior. I will start with this, not quite often, lesion, but I guess that very few pathologists know it. It's usually around ovary on the peritoneum. You see, there are such nodules. They are always multiple in occurrence, and they look like miliary metastatic disease. They are always dark brown. The brown is caused by this pigment which is iron. Yeah? And these nodules around ovaries are always sign of endometriosis of ovary. It was published already 27 years ago. Yeah? It's called necrotic pseudoxanthomatous nodules of ovarian peritoneum in endometriosis. And look, it looks identically. And even if you won't find any endometriosis, you can be sure that it is endometriosis, yeah? And first importance is not to call it necrotic metastatic tumor, yeah? So once when you know it, it will be easy diagnosis, yeah? Not knowing it, you can make a big mistake. Okay. Then this is a lesion of first was a lesion of knee joint. Which looks like these papillae that are covered by synovium, and the core of papillae is full of lipomatous differentiation. Yeah. When you see this, you can be pretty sure that the patient is having similar things in other joints as well. It must be definitely caused by some germline mutation. It's called lipoma arborescens, and it's always multiple, and it depends on what stage it is in other joints. Yeah, so that if he complains of other joints, it just tell you the diagnosis of the patient. Yeah, it looks always the same. I'm going to show you different case. Now it is different case, looking identically. And it's a mistake to call it, however, or whatever. Quite often mistake is to call it myxoid liposarcoma. Usually it is seen mostly on the knees and elbows, yeah. Very often on both knees and both elbows. Yeah. It's cured by synoviectomy. You know, tumor of the skin, precise locations I forgot. It's one of our famous cases, yeah, because it was the first ever described case of secretory, mammary analog secretory carcinoma of the skin, primary, and these patients had two mutations. One of them was classical ETV6 and 3, and another one was VCL and some other. After this case, and we published them in cooperation with Bishop one more, some 6 cases of this entity. It got into the WHO classification. Here is another case, different patient, even smaller, but still easily diagnosticable as mammary analog secretory carcinoma or secretory carcinoma called today, is typical ETV6 and 3 fusion. Yeah, it's an amazing case. It's a tumor of skin of the corner of the eye. What you see here, the first thing you see is this. It's the most conspicuous thing, yeah. It's upside down, yeah. That means the lower part is upper part of the eyelid, yeah. And I think it can be diagnosed as well-differentiated squamous cell carcinoma, yeah. I'm sure it is, but it's not all. There is other things inside of dermis. And it is, yeah. And it is this lesion, yeah. What would be a diagnosis? No,
So, ouch.
it's Hodgkin disease. And there are interesting things I hope to see it here. Here are so-called mummified cells, but it's not well seen here, yeah. The skin mummified cells. Hodgkin disease of skin is quite rare. I'm sure that nobody saw many of these cases, yeah. But if you have it, you should look for mummified cells, as in this case, yeah. And these mummified cells, here it is nicely shown. Look at these basophilic cells, often with halo around it. And they they were seen in 9 out of 12 cases. That means it's seen in majority of Hodgkin disease, but in the skin is very important because one always, pathologist is always innerly prepared or unprepared to accept the diagnosis of Hodgkin disease of the skin. Yeah. Okay, well, sparkly. But what with this coincidence of the squamous cell carcinoma? Yeah, you see, it is squamous cell carcinoma definitely, and it is just above the Hodgkin disease. How it is possible?
It's my mimo focus.
Yeah. Where? I'll make it higher a little bit.
The slide is outside.
Pytle. No to počím.
To není mikroskopem.
Co jsem vystrhl? Co to je?
To jsem tam dal já teďko, jo?
Ne.
Zkus to zaostřit ještě dres.
Nejgoď.
Tak já to vypnu. Co chce, jestli tam nějak tak...
Může Patrik,
Jo.
protože my to vidíme dobře.
Make it better. I will just speak before the system is readjusted. As to the patient, the patient was treated for Hodgkin disease, and after treatment of Hodgkin disease, the squamous cell carcinoma disappeared by itself. It proves that it was reaction to Hodgkin disease, and the reaction was practically identical to keratoacanthoma. Even the morphology is like keratoacanthoma. What is keratoacanthoma? It's not a benign tumor. In origin, it is squamous cell carcinoma which recurs itself. Nobody knows why it recurs, but here the recurrence and appearance was caused by Hodgkin disease. Yeah. We have seen. I will show you one more case or two more cases of the same phenomenon caused by different things, not by Hodgkin disease, but by infection. Něco se stalo.
Menší, teď si tam dám.
Což je zhora.
Tak.
Sorry, I cannot focus.
Sklíčku obráceně.
Ne, není.
Už jsme dobré.
Okay. Yeah, it's tumor of the skin. And the morphology is breathtaking. The peripheral part are easy to diagnose, yeah? The peripheral part of the tumor is just common clear cell nodular hydranoma, yeah? It's easy diagnosis, but inside of the hyalid nodules, I'm sure it belongs to the tumor. The tumor forms these gland structures, and these gland structures, they have myophyseal layer as well as secretory. Yeah. I've never read about nodular hydranoma producing glands having both of these structures. I have 2 more cases in my files. We even think to publish that, yeah. And to confirm that it's nodular hydranoma, the lesion had typical
CRTC1 mammal 3.
tell it for me.
CRTC1 mammal 3.
Yeah, mammal 3, CRTC1 translocation. So it shows that the lesion is really nodular hydranoma, and it is strange, extremely rare differentiation, yeah, in it. Discontinue.
Mucoepidermoid carcinoma.
What?
So it's mucoepidermoid carcinoma of the skin.
Yes, yes, anyway, yeah. I chose the similarity of being classification neighbor of mucoepidermoid carcinoma of the skin, yeah. Here I have a tumor of lip. Here a small pitfall. You see it looks a little bit similarly. Here is a small gland on the lip from which it starts. And the tumor is extremely well differentiated. And in spite of being very, very well differentiated, I'm sure it is well differentiated mucoepidermoid carcinoma of the lip, caused by, arising from small and oncocytic metaplasia, caused by arising from small mineral salivary gland of the lip. Yes, here is biopsy of the lungs. Yeah. And you see, there are lymphoid infiltrate, but beside the lymphoid infiltrate, there is a spume-like material. Do you see it? The spume-like material. Yeah. I think one more magnification. It was HIV positive man. What do you think this is?
Pneumocystis.
What?
Pneumocystis.
Pneumocystis? How?
Yerovici.
Yerovici. Yeah, not Carini. Carini it was called till recently, but it was described by Czech bacteriologist and Czech pathologist, bygone chief of our department, and the bacteriologist was called Yerovec, so that it is now called Pneumocystis yerovici, according to him. And Pneumocystis yerovici is different from Pneumocystis carinii. Pneumocystis carinii is in animals, but in humans This bug is close relative of Pneumocystis carini, but it's called now Pneumocystis jirovecii. It was described in 1952 by Jirovec and Vaněk, our chief of our department. He was here chief till 1985, I guess. Here is a tumor of anal region. And you see it's squamous cells of anus. And beside these squamous cell of anus, there are these gland-like structures below squamous epitheliums of anus. And I think very few pathologists know that there are glands in anus called anal glands, which are different from mucosa of rectum. Yeah? These are little known normal structures, but sometimes it can be incipient part of adenocarcinoma, these anal glands. And you see here the morphology of this in situ carcinoma is identical to cervix. Yeah? This hyperchromasia and P16 was positive in all these glands, so that it is definitely HPV-driven disease, yeah? Arising in anal glands. Again, anal glands are very different from rectal mucosa. Yeah? I saw only in situ lesion. That was not invasive in this case. Yeah. Yes, and here I showed in the old seminar, but I took it now. It is biopsy of skin of knee. And what do you see here? I tell you, I will show you a similar phenomenon as we saw in Hodgkin disease. It's a lesion that was diagnosed as squamous cell carcinoma. And I'm not surprised. I think it was, in a way, right diagnosis, yeah? If there was not something else. The woman had a husband, this woman, this patient, had a husband, and the husband has had similar lesion on her knee. Yeah? And
His knee.
no, his knee, sorry. On his knee. And it looked very similarly. You may see squamous cells here, yeah. But in contrast to wife, when I don't know whether it will be well seen here. Maybe it won't be well seen. There are small, tiny amastigotes inside of the cells. Yeah, I see one amastigot. Můžu šipku?
Jo, já ti tam.
Actually, for example, here is amastigot one, yeah. Here are some amastigots.
What is it?
Amastigots. Amastigots, it's a developmental level of histoplasmosis.
Yeah.
So that they was I had histoplasmosis of the skin with a huge reaction of epidermis that looked like squamous cell carcinoma, or it was squamous cell carcinoma. When the patients were cured, the squamous cell lesions disappeared. Yeah? And as they, probably one of them took it, they were in Middle East. Yeah? One of the patients brought it, and the other one infected it in the bed. It is how it may be dangerous to sleep with your wife. Yeah.
Knees and love.
Yeah.
Knees and love.
Knees to knee.
Yeah.
So, in one of these, it was easy to diagnose these mastigotes. So just the magnification here is not good enough. Yeah. But the other one, I didn't find a single mastigote at all. Yeah. Yeah, I see even here. Yeah, 2 small mastigotes here. Yeah. In many cases of histoplasmosis, here is a mastigote, the small one. You see tons of mastigotes, you see it immediately, but in some you must really look for it. Both are cured by, as I said, it cured the disease, the histoplasmosis, and everything disappeared. Yeah, I can imagine because if they would excise the squamous cell carcinoma, it would continue. They would be carving, yeah. And here the pathologist saved both of the patients, the culpable, even the unculpable. Yeah? Here is cervical lesion. You see that there is something strange in it. It's not typical morphology of cervical carcinoma. Yeah? It looks more like skin tumor, basal cell carcinoma. It's called basaloid tumor, basaloid carcinoma of cervix. It's called by HPV or adenoid basal cell carcinoma of the cervix. It has much better prognosis than usual type of carcinoma. And I have here P16, you can see how nicely it is positive. It's rare tumor, but not so rare that pathologist wouldn't see it in his life. Yeah.
Positive for beta-catenin?
What?
Positive for beta-catenin?
No. They are usually, there's some cases, and one of our cases was having FGFR3 fusion, which is true not only in cervix, even head and neck HPV-driven lesions are fibroblastic growth factor 3 fused tumors. Yeah. And yes, I have a couple of patients which are very interesting. They are lesions of the skin. Yeah. And one of them, this one was under the breast of female. Yeah. And the diagnosis was metastatic cancer, probably from the breast by clinician. What do you see here? You see, there is no lymph node. It's not lymph node, it's skin. And you should know, all young pathologists I will show you on the classical lymph node. You should know how to diagnose these changes. Do you see these? Do you see these epithelioid structures? Then there is rests of germinal center, and these structures invade it. Yeah. And beside that, there is this sinus-like structure. Maybe the second case would look like better. Yeah, here. What is the clear this part? Yeah. What is this? It used to be called, or it is still called, immature sinus histiocytosis. These cells are clearer, they are cleaved, and they are pressed in sinus. It doesn't matter that it's not lymph node. The sinus is secondarily created there. Yeah. So, what is the diagnosis? Toxoplasmosis of the skin, and the patient, had really cancer of the breast, but very small one. And this lymph node brought attention to her breast lesion. There was confirmed toxoplasmosis afterwards, and the toxoplasmosis actually saved the life of the patient, because it wasn't metastatic disease of the. I will show you another case of the same phenomenon. Yeah, this is nicer. Yeah. Typical for toxoplasmosis are these shattered or distorted germinal centers. You see them, yeah? It is the border of germinal center which is shattered and here as well, yeah? Here's original germinal center. The mantle of the germinal center is very thin, sometimes non-existent, and these germinal centers are invaded by these clear cell epithelial structures. Yeah, this invasion of germinal center with these clear cell epithelial is pathognomic. Pathognomic. I've never seen it beside toxoplasmosis. Yeah, you should prevail on the diagnosis, even if clinician will tell you there is no toxoplasmosis, because it can be chronic toxoplasmosis and the titer is not very high. Another thing to prove that it is toxoplasmosis, it's here. You see, it's immature sinus histiocytosis. You see it here. This clear. It is sinus packed with these clear cells. These are monocytoid B cells, which are very similar to cells looking in mantle cell lymphoma. Yeah? And another sign seen in only part of toxoplasmic is toxoplasmic lymphadenitis. Even this is not lymph node, skin. It's at the periphery. You see something that looks like capsulitis. Yeah. It's seen only maybe half of the cases, yeah. So that these three signs are pathognomic, you cannot make the difference. But I saw so many toxoplasmosis wrongly diagnosed as Hodgkin disease or non-Hodgkin disease, yeah. It's a huge mistake, yeah. I will find some classical lymph nodes. I will send to all young pathologists to see it for whole life, because this lesion is very common. Okay. Yes, this is lymph node. And you see the sinuses are entirely smashed and destroyed here. And you see these sinuses are replaced by this vascular proliferation that looks like that looks very similar and often confused with Kaposi sarcoma. It's so-called vascular transformation of lymph node sinuses. It's seen most often close to some lymphostasis. Yeah, there might be, for example, most often cause of lymphostasis is metastatic disease. Yeah, and when the blood is being congested in the lymph node, yeah, there starts to be the reverse flow in lymph node into the sinuses. It causes the proliferation of these vessels. It's the greatest mimicker of Kaposi sarcoma. It is female, and it is the tumor of urethra. I think that morphology is typical for one type of cancer. What would you guess? Female or urethra? It is prostatic specific antigen.
Or some,
How would you make it? It's female.
they can also have the accessory glands that are analogous to prostate,
Yeah.
but it's not really
Yes.
prostate.
We published this case, and we even found the first ever published with genetical change. Yeah? And it is the cancer of prostate in female skin glands. And these were first discovered by Mr. Professor Zaviacic. He was Slovakian pathologist, and when he first came out with the diagnosis in 70s, primary prostatic gland carcinoma, everybody told him that he's idiot. Yeah? And he took as a lifetime task to persuade, and he is recognized as the first ever pathologist describing this entity. Yeah? But this our case, which is 4 years old, we did for the first time found first molecular genetic abnormality. Yeah, I don't remember what it was. Yeah. You can read the paper. Okay, it's salivary gland. Yeah. Salivary parotid gland, yeah, with such necrotic tumor. And there are some abortive perils in it, yeah. They are not necessary for a diagnosis, but most of the cases you can find at least abortive squamous cell perils. And these undifferentiated carcinomas are typical for so-called not translocated cancers of midline, because mostly they are found in mediastinum and peritoneum, but they were described in salivary glands, which is not midline at all. It's got typical genetic fusion, usually NUTM1 with BRD4 or many others. Yeah, it's a very deadly tumor. It kills the patient extremely quickly. Yes, here I have a cervical lesion that was conspicuous by colposcopy. And when we diagnosed it, the gynecologist didn't want to believe us. So it's cervix, yeah? What is it?
Sebaceous gland.
Sebaceous glands of the cervix. Can you imagine that? If women can have prostatic carcinoma, why could not have women sebaceous gland? And sebaceous metaplasia of the cervix were first described by Professor Linhartová, that used to work in this department in the 1980s. She published in Archives of Pathology 5 cases of it, yeah, and we afterwards describe it describe it twice, yeah. You see, it's nice, sebaceous. I'm gonna play here. Okay. Yeah, tumor of the thyroid. You see, most of the tumor is caused by this proliferation of spindle cells, which looks like what? Beta-catenin positive
Fibromatosis.
fibromatosis. But there is this,
It's popular with thyroid carcinoma with fibromatosis.
yes, and this one is was caused by BRAF mutation. To first letter, to. Actually, I described it first already 33 years ago. Can you imagine that? Papillary carcinoma with exuberant nodular fasciitis-like stroma. I must say that at the time, there was not paid big attention to fasciitis-like and fibromatosis-like. Yeah. At that time, I was wrong calling it fasciitis-like because it should be called fibromatosis-like. Yeah. But we came back to the lesion very recently, 3 years ago, 5 years ago, and we published 10 cases of papillary thyroid carcinoma with prominent myofibrous stromal component. And we found that in 9 cases, the stroma looked like fibromatosis, but in 1 case, the stroma was really nodular fasciitis-like. It is the first really described fasciitis-like stroma in this lesion, yeah. And usually, all of these stroma were caused by CTNNB1 mutation, which is typical for beta-catenin mutation, yeah. And most of them were BRAF mutated, the epithelial component. These lesions behave mostly in benign way. The explanation of it might be that the stroma actually lock the tumor inside and there are no lymphatics to metastasize. But they were described, I think, 1 or 2 cases when it metastasized to lymph node. Yeah. Still the sign of malignancy. And we have seen it a couple of more times at the time, so that every pathologist will see it once. And the most biggest mistake is to consider this fasciitis-like stroma or fibromatosis-like stroma to be desmoplastic reaction for invasive of tumor. The stroma is neoplastic because it is beta-catenin mutated, and it's caused by the tumor. It's not only a reaction to the tumor, but it's really secondary things that these 2 things are in association But it's not like usually when the tumor grows into stroma and makes reactive myofibrostic stroma as a sign of invasion. It is not sign of invasion, yeah? Yeah, here one thing, we have over 100 cases of it, it was only published once in the past, and still I see it all the time, again and again. It was 3 centimeters big lump that make a tumor. And my son somehow, because you do not need genetics, he is lazy to, unwilling to publish it. Yeah, he even made very nice abstract for USCAP, but he has dropped the topic. Yeah, and what you see here is synovial metaplasia, and around it tumoriform stroma. The lesion is perfectly benign, but it imposes like tumor, and sometimes a big tumor. Yeah, it must be carved out usually. And I found that very often it's sort of sequelae on granuloma annulare, deep granuloma annulare. It's usually the granuloma annulare make a dissecting lesion, and you see that part of it is this tumoriform, like synovial metaplasia. Still, you can see there part of deep granuloma annulare. Everybody will see it quite often in the life. Yeah. Okay, I would end up here. I hope I took it as a sort of pitfalls in pathology. Yeah? And we have a pizza here now. Yeah?